All right, it's Rusty Vann, Cardiology Fellows. We're going to talk about management of heart failure. So some objectives we're going to cover today. So what is heart failure? So classically thought of two types: heart failure with reduced EF, heart failure with preserved EF. But really those, as you guys all are aware, kind of outline a cardiomyopathy. So the echo tells us that someone has a weak heart, but the symptoms they present with fatigue, dyspnea, fluid retention, that's what builds the clinical syndrome of heart failure. But you can also have heart failure with preserved EF, which is the echo would demonstrate preserved or demonstrate restricted LV filling or diastolic heart failure or diastolic dysfunction, and would lead to, with the appropriate symptoms, would lead to the diagnosis of heart failure with preserved EF. So epidemiology, two big things: 50% mortality 5 years from the diagnosis, and then the 1 month readmission rate of 25%, meaning a quarter of all patients we see in the hospital for whether it be their first decompensation or their initial diagnosis of heart failure, or the patient who comes in every 2 to 3 months with acute exacerbations. Their risk for readmission, the readmission rate is 25% in that first month. And the reason that's important, as you all are aware, with reimbursement, from a reimbursement standpoint, and then the $30 billion annually to the healthcare system purely from heart failure alone. Some risk factors for the development of heart failure: high blood pressure is the single highest risk factor, and then diabetes, atherosclerotic disease, the kind of metabolic syndrome in whole are other risk factors. So the ACC stages: stage A, those risk factors I spoke of before, but no structural heart disease. And then stage C, so they have structural heart disease, they have an echo that shows a cardiomyopathy, and then they have symptoms of stage C. So the stage C is kind of where the NYHA functional classification, which you guys are probably more familiar with, kind of fit in. So here is that NYHA functional classification. Kind of two polar opposites. Class 1, so they have no limitation on physical activity. They can kind of do whatever they want to a degree. And then stage class 4, so they have symptoms at rest. So any activity or even rest causes them to feel symptoms of shortness of breath, significant edema, significant fatigue. And the reason these functional classifications are important to remember is this kind of drives all the trials. Use these classifications to kind of derive where the benefit is gathered from the medications. Initial evaluation: someone with heart failures, so kind of nothing crazy here. EKG is important to look for evidence of old myocardial infarction or possible an arrhythmogenic etiology that's leading to their cardiomyopathy. An echo used to evaluate for a change in EF that could have precipitated a decline, and then kind of a specific lab bias. This is just straight from the heart failure guidelines. This is what they recommend obtaining in a chest X-ray to kind of evaluate, for acute decompensation. One specific lab that always comes up is a BNP, brain natriuretic peptide, or pro-BNP, which is kind of more common from some facilities. So really the utility of BNP is much more, to me, is to be used to rule out heart failure than ruling in heart failure. So if someone comes in with shortness of breath, they have edema, but they have a normal BNP, usually that would tell you that they it is from another etiology. The shortness of breath is from another etiology than decompensated heart failure. There's a lot of things that can cause your BNP to be elevated. We'll kind of look at it the next slide. There is, from the guidelines, there is some benefit to using a BNP at the time of discharge to kind of prognosticate moving forward, maybe kind of establish a baseline that you could check as an outpatient setting if there was concern for decompensation to kind of see where they're at. There's no benefit in using the BMP to kind of guide your diuretic therapy, whether it be to escalate up or to escalate down, sort of thing, in the hospital or as an outpatient basis. BMP should not be checked routinely, every 48 hours, every day, or anything like that in someone who's in the hospital. There's just no benefit to show that there's a utility. So many things cause elevation. One that's important to know, non-cardiac causes critical illness. So your patient with bacterial sepsis from a UTI can have an elevated BMP, likely due to high output state, not necessarily mean that they have decompensated heart failure. So common etiologies of heart failure or cardiomyopathy. So like 80-85% is from ischemic disease. So blockages in the coronary arteries leading to myocardial infarction that causes wall motion abnormalities. Got a next on the list would be valvular, and then toxin-induced in our patient population, meth, alcohol, but cocaine is another one that should be mentioned as well as kind of not as common, but in the past I would have myopathies, cardiomyopathies from chemotherapeutic regimens, and then kind of others in no particular order. Myocarditis from infectious etiologies, stress, Takotsubo syndrome, we see quite a bit. Another one that I didn't put on here that should be listed is arrhythmogenic etiology, so your patients with AFib, flutter, that are unaware they're in some arrhythmia, that have a heart rate of 140 to 150 for 2 to 3 weeks. They can come in with a decompensated with a low EF purely from their arrhythmia. So the workup. So kind of familiar with kind of our thoughts, what we do. So some places, everyone who has an echo that demonstrates they have a low EF will get a heart cath, no matter if they're 18 or 48. I think that we kind of follow case-by-case basis because there is, a risk to a left heart catheterization. But either way, all patients with a cardiomyopathy or low EF have a indication for a left heart catheterization, or at least something to define their anatomy, whether that's a cardiac CT, which is always reasonable to perform. There's no risk. Usually can get a good evaluation in those young patients to kind of say for certain that they don't have ischemic etiology. Really, it's important to consider the risk factors, kind of their presentation, and that kind of is what helps us decide if we think they need a cath versus would be okay with a stress test or cardiac CTA to rule out ischemic etiology. Obviously, they come in with any sort of evidence of ischemic disease, elevated troponin, EKG abnormality, they'll get a heart cath. So, kind of quick slide, just to kind of lay out what we're going to talk about before. We're here in a second. The kind of pathophysiology. So something causes injury, drops that cardiac output, leads to decreased renal perfusion, decreased carotid baroreceptor stimulation. So the body kind of tries to overcompensate, fix it itself. 2 ways of doing that: activate the sympathetic nervous system, leading to increased heart rate, increased inotropy, and by activation of the renin-angiotensin-aldosterone system, leading to vasoconstriction, increasing afterload, increasing preload. So the body has its own way to kind of help get over that acute drop in cardiac output, which both of these things will raise the cardiac output acutely. However, long term leads to further decline, further detrimental effects with the negative remodeling, worsened LV function. So the medications we use to combat the detrimental effects of heart failure kind of hit both of these regions here. So the beta blockers obviously are used to augment the heart rate response, and then we use the RAS drugs, ACE inhibitors, ARBs, ARNIs, or aldosterone antagonists, kind of over here, as you'll see here in a second. So beta blockers used to block the adrenergic receptors on the heart to limit the detrimental effects of the sympathetic nervous system. So the real benefit comes from decreasing heart rate, decreasing contractility, and decreasing myocardial oxygen demand. Class 1 recommendation in all patients with heart failure with reduced EF, regardless of the etiology, to be on beta blockade. We'll talk about the specific ones here on the next slide. So which ones do we use? Kind of a classic pimp question. three that are the trials, that were carried out to support their use in heart failure with reduced EF: carvedilol or Coreg, bisoprolol, metoprolol succinate, or Toprol XL. Kind of through this chart in here to kind of underline and show the importance of getting to that trial dose. Someone comes in with heart failure, we throw them on 3.125 of Coreg twice a day, or even 12.5 of Toprol XL, send them out the door. And they never get that dose titrated upward. Like, are we really providing them the benefit other than medication was studied? You see the average trial doses here. Big difference between 3.125 milligrams and 37 milligrams daily, which averages 12.5, 25 milligrams BID, somewhere in between there. Would obviously be the goal. And it kind of supports the importance of a dose escalation. So if their blood pressure can tolerate it, kind of get them on that maximal tolerated dose, not these baby doses that we initially start with, in order to get them that maximum effect. And that's the same with ACE inhibitors, ARBs, or Entresto, which we'll talk about here in a second. So the three trials that looked at these medications all demonstrated between a 31 to 34% improvement in risk of death or all-cause mortality in patients with heart failure with reduced EF on these medications compared to placebo. So very important. Like I said, class 1 recommendation: all patients with heart failure with reduced EF should be on one of these three medications. So what do we use to kind of augment the renin-angiotensin system? So ACE inhibitors, ARBs, or ARNI, so they work by causing peripheral vasodilation, which reduces afterload. They also inhibit cardiac and vascular remodeling. And they, again, are proven to reduce the risk of death as well as reduce hospitalizations in a heart failure population. So kind of through this slide in here, again, just to kind of underline the importance of, someone comes in, we start them on 2.5 lisinopril, send them out the door. And, sometimes we see these patients 6-8 months later and that dose never gets adjusted. Real important to shoot to get to this trial, maybe not this trial dose, but at least the highest tolerated dose to get that maximal benefit. In terms of ACE inhibitors, they actually did a trial, the ALICE trial, in 1999, which demonstrated higher doses are better than lower doses in terms of decreasing mortality in reducing hospitalizations in the heart failure population. So ARNI, or the angiotensin receptor neprilysin inhibitor. So the one you guys are all familiar with, a recent trial, Entresto paradigm trial, compared Entresto to enalapril, showed that Entresto significantly lowers hospitalizations and risk of death in heart failure with 2 to 4, class 2 to class 4 symptoms with EF less than 40%. So kind of that's kind of the strategy now should be to get them on a beta blocker and then Entresto. I think for our patient population, you'll see a lot of patients from the IHS as well as the VA. And initially there was you had to jump through some hoops to get these medications started. So I think it's still reasonable to see somebody that's acutely decompensated in the hospital to start them on ACE inhibitor, ARB, get them out of the hospital, see them in the office, and then work on getting Entresto started as an outpatient. They did this trial a couple years ago that showed that it's okay to start it acutely in the hospital, but the trial didn't specifically show that there's a mortality benefit from starting it in the hospital versus starting it on an outpatient basis. I think it's better to get them on something and then try to get them on Entresto as an outpatient or as an inpatient if you can get it worked out through insurance or whatever. But it's better to get them on something versus start them on Entresto than not be able to afford it, don't see their doc for a while, and then they go for 2 to 3 months without inhibition of that RAS system. And just like beta blockers, just like ACE inhibitors, ARB, you should really try to titrate the dose of Entresto upward to get that maximal benefit. that was seen in the trial. So kind of the next, the aldosterone antagonist, spironolactone or pleuronone, not typically started in the hospital due to, I think, just because of starting other medications, but something that should definitely be utilized for patients with heart failure. I think it's okay to start as an outpatient. You should just definitely be sure to monitor their creatinine, be sure to monitor their potassium, and follow those numbers to ensure that they're not getting worse. Definitely something that should be used, especially in patients that have plenty of blood pressure to work with. Once you get that ACE inhibitor, ARB or ARNI titrated upward, once you get their beta blocker titrated upward, they still have significant blood pressure issues. Definitely should look at aldosterone antagonists in especially patients following MI, in order to improve uh, their overall mortality. So other agents, they're supported by the guidelines. First, we'll talk about hydralazine isosorbide. So the AHEF trial in 2003 looked at African American patients with class 3, class 4 heart failure, and showed to have a decreased hospitalization as well as mortality benefit with this medication. I think it's limited somewhat use by cost. Sometimes we break it up into the components. However, that's again limited by compliance because you have to take it 3 times a day. But if you have that patient that kind of fits that group uh, and is willing to take the medication, definitely something that should be utilized in that patient population. Next is ivabradine or Corlinor. So the SHIFT trial in 2010 demonstrated reduced the risk of hospitalization in patients in normal sinus rhythm with heart failure through CF and a persistently elevated heart rate, despite being on maximal doses of tolerated beta blocker. So the ivabradine works through the funny current in the sodium channel to reduce the heart rate. Kind of limited by cost in our population, but definitely something to be considered uh, if they kind of fit the qualification. Another one, just for completeness sake, the Digoxin was showed 20 years ago to reduce hospitalizations but no benefit on mortality. I don't think in terms of OSU cardiology, it's something that we kind of pull and start very often or at all. But we see a lot of patients from older docs in the community that have patients with heart failure that are started on the Digoxin, usually something that we would continue as long as there's no contraindications. So sudden cardiac death, important cause of mortality in this patient population. Uh, as you know, there's just kind of a chart to kind of outline who gets an ICD and who doesn't. But one thing that always comes up in the hospitalized setting is a life vest. Do they need one? Do they not need one? Should we get them one? Should we not get them one? The vest trial from a couple years ago looked at life vest and really wasn't a great trial for life vest, as it did not improve mortality in terms of sudden cardiac death in the vest group versus the non-vest group. However, did lower all-cause mortality, which is secondary outcome. Really, it's just kind of I like to think of it as a patient-by-patient basis. So you have someone, especially MI, they get revascularized, EF is low, having significant ectopy during the hospitalization. That patient would benefit from a life vest. Used to be limited pretty significantly by cost. However, now kind of easier to get. IHS is kind of paying for it more. So there's just something that we should consider, but really to kind of take on a case by case basis on who gets it versus who doesn't. So here's kind of a flow chart. Down here you can see EF less than 35%, class 2, class 3 symptoms, class 1 indication for an ICD, EF less than 30% for class 1. Patients, and then just the timeline. So if they have an MI but they do not get revascularized, so no PCI, no cabbage, they have to go 40 days before implantation, versus if they get revascularized, it's 90 days before they can get implanted. So this is just another kind of flow chart that outlines where CRT or cardiac resynchronization therapy kind of fits in. I'm not going to go into that a whole lot here today, but as you can see, the kind of the real benefit is derived from patients with the left bundle with a widened QRS of 150 milliseconds that are in sinus rhythm is kind of where the class 1 recommendation falls. So the first 20 minutes talking about heart failure with reduced EF, heart failure with preserved EF. There's been a bunch of trials over the last 20 years to kind of find the golden ticket, the drug that's going to reduce mortality, reduce hospitalization in this patient population. Nothing's really panned out. The Paragon trial from a few years ago with Entresto showed no benefit in this population. The only thing that really has any recommendation from a guideline standpoint is angiotensin receptor blockers should be considered to reduce hospitalizations. I think it's a 2A recommendation in patients with diastolic dysfunction. The big thing in this population is to control the blood pressure. You want to prevent that LV remodeling, the kind of LV hypertrophy that leads to that diastolic dysfunction, or prevent further progression of that LV hypertrophy by controlling the blood pressure. So here's kind of the take-home point for what medication to use. So stage 1, diagnosis of heart failure with reduced EF. So every patient, like I said, should be on a beta blocker. Here they still list ACE inhibitor, ARB, or it's reasonable to say or ARNI at this point. Or like I said, it's reasonable to start one of these, get them out of the hospital, and then ensuring they can get Entresto for a prolonged time and then getting it started. But it kind of leads you through what you would do next. These are not mutually exclusive. You can fit in 2 or 3 of these boxes at once, but it kind of leads you, if you have African American patients, the next thing would be to consider hydralazine, patients with their class 2 to class 4 with good renal function, no trouble with their potassium, consider aldosterone. And then here is where they talk about initiating Entresto. Like I said, you can fit in 2 or 3s at once. And then here at the bottom, the indications for ICD, and then Corlinor. So kind of emerging therapies, something that was not in the guidelines from a few years ago. The SGLT2 inhibitors, I'm sure you guys are much more familiar with those than I am. Continue to treat diabetes. ImpaReg came out a few years ago, looked at empagliflozin, showed a decreased cardiovascular mortality, I think it was, in patients with diabetes that received empagliflozin. Dapagliflozin, another SGLT2 inhibitor, came up with their trial this last year that demonstrated a reduction in cardiovascular death and heart failure events irrespective of diabetes mellitus. So whereas the first trials was obviously in the diabetic population, this is irrespective of diabetes, shows significant benefit. But it's something else to consider that could be used in this population. So kind of in the last 10 minutes or so here, talking about hospitalized patients, which is, everyone's seen multiple heart failure admissions throughout their career at OSU. So someone comes in, first thing, you want to figure out whether they have known heart failure or whether they have it's a new diagnosis, to figure out, kind of what the etiology. So ischemic injury, medication noncompliance, sodium fluid restriction noncompliance, or the kind of other etiologies we talked about before. If they're on chronic management, you should continue their therapy as long as their renal function tolerates, as long as they have no hemodynamic compromise. One thing that always comes up is if we should continue beta blockers. I think that as long as they're not in the ICU, so they're not hemodynamically compromised, it's reasonable to continue their beta blockers that they've been on. I would say that we typically would not recommend starting beta blockade on someone who's on IV diuretics that either wasn't taking it at home or had never been on a beta blocker. Usually we would wait until we transitioned to PO diuretic therapy before we initiated our beta blockers. And then obviously use caution, maybe wait 24 or 48 hours more in those patients that were previously on Inotropes. So another thing that comes up quite often, diuretic therapy, do we throw everyone on 40 IV? Do we throw everyone on 80 IV? Kind of what the goal. The JACC published this diuretic therapy for heart failure patients last month. They kind of looked at some specific things with loop diuretic therapy. Kind of their goal, what they recommend is 2.5 times the outpatient dose. So if they're on 40 milligrams POBID, you should start them on 100 milligrams IVBID. And then one thing they were big on that they commented on You start them on that, and then you reassess them 2 to 3 hours to make sure you're getting that augmented diuresis that you want. And if you're not, you increase the dose of your diuretics at that time, and give that next dose now, not waiting 12 or 8 hours before the next scheduled dose to decide, should I do more, what the plan should be, because it's important to hit them with that dose, and if it doesn't work, increase the dose and hit them again and see if we can get some of that fluid off. Dose trial from a few years ago showed there was no benefit in continuous IV drip versus high dose bolus therapy. Kind of in our institution, I would say we use the bolus therapy 95% of the time, whereas other places do the continuous drip more. It kind of just depends on kind of what you're familiar with. Ultrafiltration comes up every once in a while. Because the Caress trial, Caress HF from a few years ago didn't show an benefit in terms of mortality in ultrafiltration versus medical therapy in this population, but I think it still has a 2A, 2B recommendation in the guidelines if you're not getting the response with escalating doses of diuretics. So reasonable to consider ultrafiltration to get some of that fluid off. This comes from the Jack article. They mention, it's important to realize that you hit them with that dose, they have adequate urine output, they're getting better, but their creatinine bumps a little. It doesn't always mean that, we're throwing them into renal failure. It doesn't mean that we should stop our diuretics or that we should give them a bolus of fluid. We should need to watch it closely and understand that it can elevate acutely, but if we're getting the response we want, and as long as we kind of closely monitor, it's okay. It's something we should just need to monitor. And then you guys are familiar with using metolazones or oxalin to kind of augment. Just real quick on strict eyes and nose, important for the nurse and the patient to understand, why we are giving these diuretics, why we care about how much urine they're making to kind of guide our therapy. That's not to say that every patient needs a Foley catheter, but if they're incontinent, then it's definitely helpful to see where we're at from a diuretic standpoint. And then those patients that come in with acute renal failure with decompensated heart failure, I think it's important that they get a Foley catheter to closely monitor that urine output to ensure that we're hitting our goals. So the other thing that's important kind of prior to discharge is education. Patients with heart failure need to understand heart failure self-care. So they've done studies to look at patients that receive this education, kind of follow this education, and they do better in terms of readmission rate than patients who do not. Patients need to kind of understand why we want them to monitor their weight, why we want them to weigh themselves daily, why we want them to restrict their sodium, because all that better education leads to improvement in our readmissions, decompensations, that sort of thing. And then they need to understand the importance of medication compliance and how all these medications kind of work together to keep them from bouncing in and out of the hospital. Ideally, kind of like the titration of the medication I talked about before, a lot of this would be done with a heart failure clinic or a transition of care clinic. Unfortunately, we don't have that available to our patients, so it's really important for not only the cardiologist but the primary care doc to ensure that they're getting this education, because you guys will be the first ones to see them 2 to 3 weeks after they get out of the hospital. Can make sure that they're weighing themselves daily, make sure that they're restricting their sodium, their fluids, and then again work on titrating those doses of those medications upward to get to that therapeutic dose to improve, to get the the desired outcomes. Just a quick thing on sodium restriction, we always usually 2 grams, kind of where we go of data. There's not a lot of great data that says that 2 grams is better than 1,500 is better than 3 grams. In the guidelines, they say, A and B, maybe less than 1,500 grams is better. And then, as it goes forward, it's much less clear, maybe a more liberal strategy. Just important for them to understand why they're on a sodium restriction and kind of how to follow that. So kind of finishing up here, cardiogenic shock. As you're all aware, severe hypotension from severely reduced cardiac output. Clinical findings usually elevated lactic acid, altered mental status, cool, kind of clammy extremities, and that hypoperfused state. Um, you see this patient, kind of what do? When it's reasonable to always start with Levophed or norepinephrine initially while you're trying to work up and see if this is from, are they septic from pneumonia, UTI, this is purely a heart failure standpoint. Once, everything kind of is leaning more towards a heart failure standpoint, it's reasonable to consider a Swan-Ganz catheter, especially if you're going to use inotropes, which we'll talk about here in a second. But I think that if we have a patient on dobutamine, milrinone, kind of the classic inotropic therapy, then we need a Swan to kind of help guide us that direction. And then in those patients that kind of are refractory to medical therapy, should we consider circulatory support with the balloon pump versus Impella? The data on balloon pumps is not great, not used as frequently now as they were. I think even when I was a resident, it felt like we used them a lot more. And then Impella, again, data on Impellas is more kind of registries that show benefit kind of specific populations, but definitely have risk with their use. So pulmonary artery catheters, as you all are aware, there's no benefit in everyone in the ICU having a pulmonary artery catheter, but I believe there is benefit in specific patient populations, most specifically patients with heart failure. The ESCAPE trial kind of demonstrated that there did not improve outcomes. However, they excluded the patients that I think would benefit the most, those that were on inotropes. The guidelines support class 1 recommendation for patients that continue to have respiratory distress or clinical evidence of impaired perfusion, and you can't determine their volume status from clinical assessment alone. So like I said, any patient that were, IV high dose diuretics on inotropes, on IV peripheral vasodilators, that sort of thing, really need a Swan catheter to kind of help guide that management. So inotropes, dobutamine, milrinone are kind of the two specific for heart failure that we think about. But like I said before, Levophed is always reasonable to start in the acute setting and then maybe transition to one of these as kind of the clinical picture becomes more clear that it's a heart failure that we're dealing with versus kind of septic. Like to think that milrinone has a better or a less propensity for arrhythmias. However, that really has never been proven to be the case. Kind of use these interchangeably in specific situations. Milrinone has a longer half-life and is cleared renally, so in patients with renal failure, probably not the best drug. But really, I think you'll kind of see that providers kind of have one that they go to 80-90% of the time, then only use the other one. Maybe when they can't use the one they normally use. Here's just a kind of a chart, kind of outlines shock. So just real important to know, there's no benefit in using the inotropes, milrinone or dobutamine in that patient population who has a good blood pressure. Using your inotropes isn't going to help augment your diuresis if their blood pressure is already stable. Where you get that benefit is patients that are in the hypoperfused cardiogenic shock state. So discharge planning, once you kind of do everything, get them tuned up, ready to get them out of the hospital. Big thing, like I said, in our facility, unfortunately, just don't have the resources for heart failure clinic or transition of care clinic. So you guys will be seeing them first, get that close follow-up, be able to check on them, escalate those doses of those medications as able, and then just kind of ensure they're following their fluid restrictions, sodium restriction, they're taking their diuretics, they're doing okay to kind of prevent that readmission and keep them, make sure they're doing okay. So just real quick on advanced heart failure. So these are class 4 symptoms, so symptoms at rest, and then really just threw this in here to kind of define it and then speak to these patients that are at this state. They have significant heart failure syndrome symptoms at rest. Usually at that point, they need to be referred to a heart failure specialist. That would usually be something to be done by the cardiologist, just so you guys are kind of aware of why your patient may be seeing two cardiologists. And the data has shown that it's better for them to establish, if you think that they're going to get to this point or they're at this point, it's better for them to be established with that advanced heart failure team prior to them acutely decompensating, sick in the ICU, then everyone's trying to run around, kind of figure out what's best for them. It's better to get them established early and then get them either an LVAD or kind of to transplant whenever they're able. So one way to kind of support them is with an LVAD, mechanical circulatory support. Really just threw this in here because they're starting to be implanted at Hillcrest, and then just not a lot of hearts to go around for heart transplants. These patients are living longer, so the frequency of LVAD implantation is going up. So eventually one of these, you guys are going to have to take care of one of these patients, whether it be in the office or in the hospital, specifically at OSU. I think that it won't be long before we'll have one of these patients hospitalized here, just due to the increased frequency of implantation here in Tulsa. Here, kind of what it looks like. Two big ones, HeartMate, HeartWare. This is the HeartMate, I believe. Both work the same, just the pump looks a little different. So they pull blood from the LV, pump here, and then spits it out into the ascending aorta. So as you can imagine, complications are bleeding complications because they're anticoagulated in order to prevent thromboembolic complications from the pump, such as stroke. And then the other big complication is infection because they have this drive line that's connected to this pump, which is outside of their body, usually goes subdiaphragmatic and then through a port. So one of the common kind of complications is infections here at this drive line. So the drive line connected to a control panel with two batteries, which they kind of wear at all times. But just wanted you guys to kind of be aware with the increased frequency. I think that's something that we'll see, especially with infection and then the complications, bleeding, and stroke. This just talks about morbidity mortality is significantly reduced when MCS is used prior to development of that advanced heart failure and acute decompensation, like I said before. All right, that's all I have. There's some quick take-home points. Big thing, education. It's important for the patients to know why we want them to weigh themselves daily, why we want them to restrict their sodium, their fluids, why they need to be compliant with their medication regimen. Because education has not only been shown to improve quality of life in a heart failure setting, but also to improve readmissions, acute decompensations, that sort of thing. And then in a setting where we don't have that support team to follow these patients every other week, monthly, that sort of thing. From a pure education standpoint, it kind of drops back some of that to the primary care doc and the primary cardiologist to make sure they kind of understand what we're doing to help prevent those decompensations. In terms of treatment, it's almost, I would say, simple, easy, follow the algorithm. Everybody gets on a beta blocker, and then you kind of see where they fit in for that next medicine. Like I said, it's okay to start lisinopril, losartan, and then get them on Entresto as an outpatient basis once you know for sure they can get the medication for an extended period of time. Either way, whatever strategy you choose, important to remember to escalate those doses. We got to get them to those doses that were studied in the trials to get that maximal benefit. And you guys will see them more frequently and before we will in the cardiology office. So it's always appropriate if they got blood pressure to work with, get those medications titrated upward, and then we'll see them again 3 to 4 weeks later. Can adjust the dose again, kind of get them to that highest dose, kind of in the quickest, safest amount of time. Important for them to understand, risk factor modification, controlling their diabetes, controlling their blood pressure, that sort of thing, and then importance of inpatient diuretic dosing and paying close attention to their eyes and nose, not throwing everyone on 40 IV and kind of seeing what happens. It's important to put them on something, check them 2 or 3 hours later to ensure that we're getting that response so that we don't waste time in the hospital, them getting 40 milligrams of Lasix, when they take 80 at home and having no diuretic response. It's important to check on them, follow them, make sure we're getting to that diuretic effect that we need. That's all I got. If you guys have any questions, you can email me or catch me in the hall. References. The big one's just the heart failure guidelines, real easy to find.